So tonight's topic is going to be varicose veins. How treatment can keep you healthy and active. When Mike asked me to do this topic, I mentioned how much detail we could go into on the subject, and he just said, I want to know why. Why is taking care of varicose veins important? So here we go. Mike just gave you my disclosures, except I work for the Center for Vein Restoration, not the Laser Vein Center currently. I want to say thanks for these slides to Evan Harris, who is one of my partners on the East Coast in Connecticut, I believe, and Bud Schuler, who is a vascular surgeon in Florida, and Kathy Gibson and Mark Meissner, who are out of Washington. Mark is a professor at UW. So I'm a phlebologist, and we're going to talk about phlebology. Phlebology is the medical specialty devoted to the diagnosis and treatment of patients with venous disorders and varicose veins. Why talk about this? Well, because varicose veins problems are often a hidden disease. They give an unseen physical dysfunction. It can, depending on which study you look at, it can hit up to 40% of men, 50% of women during their lifetime. It results often in an inability to exercise, which impacts your overall health. How come your blood pressure won't come down, your weight won't come down? How come your blood sugar stays high if you're diabetic? It's because it hurts to exercise. It can impact your job performance. It can result in other things like deep vein thrombosis, ulcers, lymphedema, and generalized poor health. My motto since I first started the Laser Vein Center has been healthy legs give you a healthy life. And early intervention can prevent serious vein disease, allowing healthy activity to continue. And now I'm going to unpack that a little bit for you. We're going to talk first about the spectrum of lower extremity venous disease. We'll talk a little bit about the pertinent anatomy, who gets it, why people get it, what are your treatment options, and then we're going to briefly hit on blood clots, thrombosis, both superficial and deep vein thrombosis, and a little bit about lymphedema. To be specific, we are not talking about joint pain like osteoarthritis, pain in the knees, pain in the ankles. We're talking about aching, fatigue, heaviness in the legs, throbbing pain, burning, stabbing, cramping, especially at night, swelling at the end of the day, itching, restless legs, numbness, lymphedema. So this is one example. These are spider veins. Telangiectasias, they increase with frequency as we age. They are more common in women. They can indicate that you have more disease underneath these surface veins. But 85% of these patients are symptomatic. Dr. Weiss, and Bob Weiss and Margaret Weiss, who I did some training with, are professors at Johns Hopkins, and they did a study with 100 people with these spider veins in a row who came through saying they didn't have any pain, but they still wanted treatment. And they were treated with injection sclerotherapy. And then he went back and asked them how they felt, and 85% of them said, oh, I feel so much better. They didn't even realize how much pain these were giving. Reticular veins are the little blue veins that are a little larger than the spider veins just under the skin. They can also be symptomatic. And this is what people usually think of as varicose veins, with the bulging, the obviously bulging large finger size vein. This person actually went through treatment, and you can see it looks much better. And then this is a person with lymphedema, pre-treatment. This can be a result of untreated vein problems. This is following successful treatment, probably took 6 to 12 months to get to that point. But be aware, you don't have to have visible veins to have a problem. This is a woman named Anita who came to me in Anchorage. She'd been medevaced from, she's given me permission to use her name. She'd been medevaced from Valdez to Anchorage 3 times because her legs hurt so bad they thought she had a blood clot in her leg. So she had to come in to get checked in Anchorage. She'd been seen by neurologists and surgeons and cardiologists, could not figure out what was going on. And you can see that there are no visible signs of vein disease on her legs. We're going to talk more about her in a minute. But first, we got to talk a little bit about vein anatomy. In your legs, You have the deep, which is the light brown or tan color system, the femoral vein, and you have the blue and the pink, which is superficial veins. These veins are designed to carry blood back to the heart, obviously. And if you have problems in that distribution of the greater saphenous vein, you get skin changes, which are seen often on the medial side of the ankle, and this can indicate future problems. The problem is that the veins fail. Your calf muscle acts as a pump. When it squeezes, it causes blood to move forward towards your head. The valves, if the valves are working correctly, there's no backflow here. But if the valve fails, as you can see in this diagram, then the blood is flowing backwards towards your feet. This is what we call reflux or venous insufficiency. How do you tell the difference? Well, you got to have an ultrasound. And with an ultrasound, you can begin to see what's going on in a leg vein. On an ultrasound, all fluid looks black. But if the fluid is moving, we can assign it a color with an ultrasound. So if you take this image and rotate it 90 degrees so the left is up and the right is down, that would be how this is done. So in other words, this person is standing, not lying down. When you're challenged by squeezing the calf, you can see there's a blue, there's blue that happens with blood flowing towards the head, and there's no red except for just a little bit. Now, if we go to the next slide, also this is a video, you'll see that when we squeeze, there is the red indicating blood is flowing towards the feet. So this person has veins which have failed. So this is what Anita had. When we challenged her with the squeezing of the calf and looking at the ultrasound, her legs lit up like a Christmas tree. She had managed her pain on Percocet and Valium. She could no longer do P90X, but with successful treatment, she was back to her daily routine of P90X and had a much healthier life. But we're going to talk now about the cutaneous chain of events that happens when you have veins that have failed. First, you get the enlargement of the veins, and you get edema and induration. You can get pigmentation changes, dermatitis, atrophy blanche, ulceration, infection, and further complications. So it's about to get ugly. If you don't like funny pictures, now's the time to look away. So we have a C scale, we call it. C0 is no visible disease like Anita's. C1 is just spider veins and telangiectasias or reticular veins. C2 is bulging varicosity. C3 is swollen legs, whether you have bulging varicosities or not. C4 is when you start to get skin changes. And usually it's in a gator distribution. It's called they're itchy, scaly patches, and the hyperpigmentation in the legs is from red blood cell extravasation and hemosiderin deposition, giving you rusty legs. It can progress from C4A to C4B. You can get pre-ulcerative disease. You see the white changes here of what's called atrophy blanche, lipodermatosclerosis. Lipo is fat, dermato is just under the skin, and sclerosis is a scar, so that's subcutaneous fat scar. This can happen in 7% of adults over age 50. This is what we call stage 4. Stage 6 is an ulcer. Stage 5 is a healed ulcer. Sort of looks like this right here when they've healed, but it usually occurs around the ankle or if it's from the greater saphenous vein, or in the back if it's a small saphenous vein. So this is the primary problem in 50 to 85% of ulcers. Less than 10% of people with ulcers in the legs have isolated deep system disease. This is a person that has all the changes, C4, C3, C4, C4B, C5, and C6. It can get really ugly. But the cost is substantial. Outpatient medical cost is almost $18,000 per year per patient, and that's $2.5 billion per year in the US. 2 million workdays lost because of this. So to review, healthy veins have good valves that move blood forward. Diseased veins have weak valves. Symptoms end up being leg pain, aching, cramping, fatigue, itchy, burning, swollen legs, restless leg syndrome, and ulcers. When your legs start to look like this, then it's time to get checked. 40 million Americans have vein disease, but only 6 to 8% receive adequate treatment. It's 5 times more common than peripheral artery disease, #1 cause of edema in patients over 50 years old, and 50% of women over age 50 suffer from chronic venous insufficiency. It's a hereditary disease. They looked at 134 families with vein problems. The risk of developing varicose veins was 89% if both parents had varicose veins, 47% if one parent had vein problems, 20% if neither parent had varicose veins. So it's a hugely genetic problem. Inactivity makes it worse. This is an old study, but they looked at about 3,000 patients in a factory. 64.5% had jobs standing in one place, 29% had jobs requiring prolonged periods of sitting, and only 6.3% had jobs allowing frequent walking. So the movement, the activity makes things better. Pregnancy makes it worse. I'm sure many people know that, but they looked at 405 women with varicose veins. 13% had 1 pregnancy, 30% had 2, and 57% had 3 pregnancies. Most people think that's because of the large uterus putting pressure on the veins, but it's actually more of a hormonal problem, and it's a result of the progesterone released by the placenta during the pregnancy. In some families, it helps the veins to dilate up, and after a while, they don't go back. So, how do you treat vein problems? First, you do conservative compression therapy. You want graduated compression stockings which are tighter at the ankle than they are at the thigh. It provides a gradient of pressure, so it helps to move the blood out of the legs and up to the heart. Compression stockings need only be knee high. This gives you 85% of value of the thigh high. Should replace them every 6 months to assure that they maintain the proper pressure. You can get plenty of colors. You can match the color of your veins and match the color of your outfit, whatever you need to do. These are not the same as TED hose. TED hose are the white garments that they often give post-surgery. They're meant for non-ambulatory supine patients. They do a good job of decreasing blood clots after surgery, but they do not provide sufficient pressure for ambulatory patients. So if you're in the hospital and you're horizontal, fine, but once you're vertical, you need graduated compression stockings. TEDs are not graduated. Exercise is helpful. It reduces the symptoms such as aching and pain, reduces ulcer recurrence, speeds resolution of superficial phlebitis and deep vein thrombosis if you can do at least 30 minutes daily. Walking is best because you get that calf muscle moving. When do you seek treatment? When the pain or swelling are unresponsive to current conservative measures, if you're unable to tolerate compression, when you start to see skin color changes, suggestive of venous insufficiency, or you have ulceration or hemorrhage. Current approaches, some considerations. Most people have a combination of problems. They have a combination of small veins and large veins, so you have to use different methods for different types of vein, and you're probably going to require more than one treatment, more than one visit. In general, you have to treat the bigger veins before you go with the smaller ones. We use multiple modalities. I'll review some of these. Spider veins are treated with cosmetic sclerotherapy. We inject into the veins like you see right here. A solution, we use either polydocanol or sodium tetradecyl sulfate, which is designed to irritate the endothelium or the inside of the vein, causing it to fibrose and go away. But it requires multiple treatments. This is day 1, after the first treatment, after the second treatment, after the third treatment. And you have to know that they might come back. They come back frequently, and people need often to have repeat treatments in a few years. Reticular veins, same thing, very similar to spider veins. Now, larger veins, the bulging varicose veins, can be treated with ultrasound-guided sclerotherapy. This is a needle that is injecting sclerosant into the dark fluid of the vein here. We use a detergent sclerosant, and it can be quite effective. We combine that often with what some people call a micro-incision phlebectomy. I call it an ambulatory phlebectomy. And we make a tiny nick in the skin, insert a special vein hook, hook the vein, lift it up, as you see right here. This is before and after ultrasound-guided foam and phlebectomy. Looks considerably better to me. My favorite procedure for the saphenous vein is the radiofrequency ablation. This is a catheter that is inserted into the vein. It goes up the inside of the greater saphenous vein. It's a 7-centimeter length metal piece at the end of the catheter that gets to 120 degrees Celsius. It's designed to damage the inside of the vein in 7-centimeter segments, and as we move it down the leg, that damages the wall of the vein enough that the vein goes away 98% of the time. Vein stripping, people still ask me about vein stripping, is a thing of the past. It was a surgical procedure that required an operating room. You had to strip the vein out in between 2 incisions, and you had to be asleep. People had serious pain from this, sometimes taking 6 to 8 weeks to recover. There were other styles of vein stripping as well, but you can imagine that this results in permanent disfigurement, and people were not happy with it. The treatment at this point was worse than the disease. Ablation treatments are 1 to 2 hour office-based procedure, no hospitalization. We don't need to put people to sleep. They can resume normal activities same day, rare side effects, good cosmetic outcome with no scarring. This actually shows the tip of a laser. You can use laser for this, and I did do several thousand cases with lasers. This is what it looks like post-ablation with no phlebectomy. This person's veins sort of resolved, but individual results vary. The newest technology, or 2 new technologies, one is Venaseal, which is a superglue, really. It's a cyanoacrylate moiety. We put a little catheter into the vein, and then we put little drops of glue in, put pressure to cause the walls of the vein to stick together, and it works very well. It only requires 1 little IV stick, better than 90% success. Varithena is a similar thing. We put a foam of polydocanol into the vein through an IV, fill the vein with this foam, and the vein is caused to fibrose and go away. Most people like it and recommend it to their family. There is a recurrence rate always of about 15%. Rare complaints of significant discomfort. We expect walking following the procedure. People occasionally use ibuprofen. They can return the same day, exercise the next week, some bruising, mild soreness. Does loss of the vein cause future problems? Well, if you think about it, the blood is flowing down to your feet already, so you haven't lost anything. And that minor vein only carried 10% of the blood out from your leg to begin with, if it was working, and it's not working now. And so removing the backflowing vein doesn't do anything to hurt your system. Some people say, what about isn't that the vein they use for heart bypass? And it is, but nobody wants to put a bad vein into your heart. That's not something they would have used in you. Covered by insurance. Most cases of symptomatic varicose veins are not considered cosmetic and are covered, but visible veins are symptomatic 92% of the time. So if a person's had a trial of compression stockings, has an ultrasound that shows a problem, has tried other things like over-the-counter medications, it is covered. And this is, on the left is pre-treatment, on the right is post-treatment. Here's another one. This person had an ulcer, and this is 4 to 6 weeks after treatment of the vein. So, a couple of comments about blood clots. The superficial venous thrombosis. Remember, there is both the deep system and the superficial system. The greater saphenous vein can get a blood clot. And the most common risk factor in superficial venous thrombosis is varicose veins, 85% of the time. What people don't know is there's an incidence, depending on which study you looked at, of 6 to 40% of the time of an associated deep vein thrombosis. And in recent studies performed by Dr. Gibson, there's a symptomatic pulmonary embolism, meaning a blood clot that's traveled to your lungs, that's found between 2 and 13% of the time. In addition, if you've had COVID, it markedly increases your risks of blood clot, and that's becoming more and more clear. In fact, at University of Washington, if you get COVID, they won't do any procedures on you for a minimum of 3 months while they let your body figure things out. Deep vein thrombosis, of course, is the blood clot in the deep system. It can become an embolus where it goes to your lungs. 2.5 million Americans are affected each year. 300,000 die from them, and 600,000 are hospitalized. So lots of things lead up to it, but if you have problems in the superficial veins, like the saphenous vein or bulging varicosities, like we discussed a little while ago, that getting those fixed is really will help to prevent future problems. You can, if a deep vein thrombosis is not treated, you can get what's called post-thrombotic syndrome. This happens about 30% of the time. The valves in the deep system are permanently destroyed, and you get permanent leg pain, swelling, changes in skin coloration, and venous stasis ulcers. It gives often permanent disability. This is another person who has post-thrombotic syndrome, and you can see that his right leg is much more swollen than his left leg. And there's a skin discoloration right there at the ankle. Risk of progression, SVT to DVT, some studies go up to 40%. Generally, they say around 20%. DVT to post-thrombotic syndrome does lead to chronic disability, PE, death, but prevention is the key. A couple thoughts on lymphedema. In your leg, you have the veins which carry the large molecules and the red blood cells back to the heart, but you also have an associated and parallel system called the lymph system, which carries the fluid and smaller molecules back to the heart. They work in tandem, and in your veins, if you have venous insufficiency, it's untreated, it can lead to damage to the lymph system. This is a person here who has, we call it phlebolymphodema. So this is lymphedema as a result of a damage to the lymph system from untreated venous insufficiency. And this is a person who was diagnosed in September, has obvious swollen legs, December and April. Imagine what it would be like to walk on these legs or to try to exercise as opposed to these legs. With treatment, there can be substantial improvements. Same thing here. Dramatic. There's 5 million people in the US that suffer from lymphedema, and not very many get the treatment they need that help prevent progression. One of the things we do have at our disposal is a FlexiTouch medical pump, which is a pneumatic pump. It gives a progressive squeeze up your legs to help to move that fluid out of your legs, and can be a life changer for many people who have troubles with lymphedema. Those lymphedema and blood clots could both be an entire lecture on themselves. We just skimmed over that. So why treat? Untreated veins can severely impact your quality of life, gives you disability, inability to exercise, chronic pain, ulcers, blood clots, lymphedema. The take-home messages are many new and simple treatments to correct these issues and give you the healthy legs so you can have a healthy life. Any questions?
Yes, I have a question. Where's the research headed relative to the whole issue of varicose veins? Where's the attention on research these days?
You know, they made such a jump from when they did vein stripping to the endovenous treatments that require a thermal damage to the veins. Now the people are moving mostly to non-thermal treatments like the glue and the Varithena. And the next thing that they're discovering is that people not only have varicose veins in their legs, they also have them in their pelvis many times. And many women have pelvic pain from varicose veins in their pelvis. They have varicose veins around their ovaries, and it can give a tremendous discomforting pain. There are good treatments for those now, but we don't have those here in Fairbanks currently. That's what I use Dr. Gibson for.
If you map the development and treatment of varicose veins over the last, I don't know, 20, 30 years, what is the history? What are the big landmarks that have?
The combination of the ultrasound and the inside the vein heat took us light years ahead. You may remember when we did open cholecystectomies and it took 6 or 8 weeks for somebody to recover from that. And now we went to laparoscopic cholecystectomies and you're back to work in 3 to 5 days. It's a similar difference, except, you know, people would be off their feet for 6 to 8 weeks after a vein stripping, and we can send them back to work 2 hours.
Notice one of the photos of some of the skin damage. It almost looked like it was it concentrated around the sock.
Yeah, that's what we call the gator distribution right around the foot, and that was one of the. It's like a snow gator like you use skiing. All that pressure goes sort of circumferentially down to your leg, and that back pressure causes the skin to thicken, and you get the blood hemosiderin deposition from the iron in the blood, and that's where the color comes from. Eventually it gets thick enough that it doesn't heal well, you get a little nick and you get an ulcer.
And do you see patients coming in from other physicians making a referral, or people just notice they have issues and they come to you?
Both, we do both, yeah. We don't require a referral for people to come, yeah.
Very good.
All right, thank you.
Thank you very much.